enlighten us today about the emerging concepts in newborn septic shock. Koert's research interests include cardiac function and development in preterm infants, the patent ductus arteriosus, and novel echocardiography techniques to measure cardiac function in newborn infants. Without further ado, the floor is yours, Koert.
Thanks, Rahul. Let me get my slides up. Is this all up? Is this good?
Yes. Yep.
Yep. All right. So welcome everybody, and thanks for listening today.
Recording in progress.
I'm going to bring up some new concepts in septic shock management, and the concepts are, as usual, coming from the adult world and sort of tinkling down into pediatrics and now into neonatology. So I have no particular conflicts of interest to declare, but I am going to say I do love physiology, and I'm going to talk and try to explain some of these concepts and why they are probably also suitable for us. Applying to the newborn baby as well. So septic shock, and these are the babies. This is the babies we generally deal with. We either have a bigger baby who comes from outside or inside, depends on what kind of service you provide, or we have even more of them. There's little preterm babies on the right with their late onset sepsis. And it's a big problem, particularly related to mortality. 1 in 7 deaths in the NICU is due to an infection, and I think that's really important. Here are some incidence and mortality numbers, starting with the term babies, early onset sepsis and late onset sepsis. And then you can see the incidence significantly increasing in preterm infants, particularly for late onset sepsis in very preterm infants, and so is mortality. What is actually less reported, mortality if you have septic shock, so if you already go into that metabolic and circulatory derangement, is of course naturally much higher than the overall mortality of sepsis. But there is very few data available which tells us how many of these babies progress from sepsis to septic shock. 1 second, let me get rid of this. How do I get rid of that? All right. Do we have a definition of sepsis and septic shock? No, we don't, but there is now an international consensus definitions in adults, which I think is applicable in our population as well. The definition here of sepsis is a life-threatening organ dysfunction due to a dysregulated host response. And the definitions of septic shock is then having underlying circulatory and metabolic abnormalities that significantly increase mortality. And the bulk of this talk will focus on septic shock. Sepsis is organ dysfunction, and all of your organs can be involved, whether it's the lungs, the heart, or the brain. But the organ which is actually most involved in all age groups is actually the vasculature. The vasculature plays a very important role in the progression also from sepsis to septic shock. Septic shock is then defined as having abnormalities which increases mortality risk, and that's maybe not as well defined yet in our neonatal population. We know that there's differences between demographics, whether there is immune suppression, some sort of genetics involved. We heard a great talk from Jim Wynn about the NSOFA score, which determined with what kind of support you're given are certainly related to mortality risk. And I'm going to talk during this presentation on cardiac ultrasound findings and how they also can be used to determine mortality risk. The degree of left heart dysfunction, either systolic and diastolic, and the presence of pulmonary hypertension and right heart function. If you look at the components of cardiovascular abnormalities in sepsis, then these are the 4 components. There is an inappropriate vasodilatation, which leads to a reduced afterload. There's a relative hypovolemia, which I'll explain in a bit more detail later, which reduces preload. Then there is various degrees of cardiac dysfunction, either systolic or diastolic, and then is with or without the presence of pulmonary hypertension, which can have an influence on right ventricular function. So it starts with vasodilatation. And this is an old diagram which describes with sepsis or tissue hypoxia, lactate acidosis during different metabolic pathways and changes either to the nitric oxide pathway, the ATP pathways, or the vasopressin sort of pathways. At the end, they all lead to vasodilatation. Now, vasodilatation takes place everywhere in your cardiovascular system. So not only it happens in your arterial system, where it will affect mostly the pressure, which is a part of the afterload of the heart, but it will also give vasodilatation in your veins, which is more related to volume and volume changes, which we often call preload. Now let's talk a bit more about this preload and the physiology behind this preload. If you want to describe the venous system, it's often described as this big sort of chunky kind of vessel where the top, the arterial system, fills it up with blood. And if you would stop that circulation, you can measure the mean circulatory filling pressure. That's the pressure within the venous system if it wasn't moving. And then, of course, there's a connection to what we call the central venous pressure to the right atrium, which is an important part of preload. But this is, of course, not that simple. There is a differentiation between the two. The venous system is capable of sort of having a part which it doesn't use by having this sort of tube inside this big vessel, which it can manipulate up and down. And whatever is underneath in the vessel and underneath this opening tube is actually its volume, but it's unstressed. It's not generating any pressure, which can be used for central venous pressure. However, everything on the top is pressure generating, and this is called the stressed volume within the venous system. So in normal situation, this is then the central venous pressure, where it is determined by the stress volume within the venous system. However, in sepsis, with venodilatation, this column of stress volume is generally lower. However, how much lower it is and how much the system can adapt to still manipulate the central venous pressure is not always that clear. So I've explained preload and afterload changes based on just vasodilatation, but there is also different direct effect of the host response due to infection on cardiac function. There are various immune modulators, whether they act direct or indirect on the myocardial cells and their metabolism. And you got to sort of imagine and realize that the highest numbers of myocardial cells, which are the essence of your cardiac function, are located in the left ventricle. This is already true as an early fetal age, and that continues throughout the rest of your life. Which means if immune modulators particularly attack myocardial cells, the problems are, of course, first expected into the left side of the heart, particularly the left ventricular side. So the first aspects of sepsis generally can be seen as left ventricular dysfunction. However, if your left ventricular function is not optimal, what happens is that you need more filling pressure to fill up this heart. Therefore, the left atrium has to pick up its pace and do its work a little bit harder, and it does that with increased left atrium pressure. And this is what we call diastolic dysfunction. Well, with increased left atrium pressure downwards, then you get increased pulmonary pressures, which we usually call pulmonary hypertension. And then downwards from that, if the pressure is too high and the afterload of the right heart is too much, then you can have added right heart dysfunction. So there's a cascade flowing usually from the left ventricle all the way downwards to the right heart. And the tempo in which this takes place is certainly not known. What we do know from adults and children, we look at various studies which looked at cardiac dysfunction during children and adults with septic shock. They looked at left ventricular function, systolic, diastolic, pulmonary hypertension, and this right ventricular systolic function. And they found that the incidence in infants with, in patients with shock was about 10, 15 to about 40, 45%. So at least 1/3 of the patients would have abnormalities. What is I found interesting and sort of fitting with this physiological concept of this backwards cascade, that the effect on mortality of the other systems LV diastolic function, pulmonary hypertension, and RV systolic dysfunctions were higher than of left ventricular systolic dysfunction. We looked at the cardiac dysfunction and sepsis in a group of very low birth weight infants, and this was the first study looking at this specific sort of concept, and particularly prospectively and over time. And we found that blood flows, whether this was from the right side, RVO, right ventricular output, or from the left side, left ventricular output, when it started, was very high. Stroke volumes were high, and this is what we call warm shock. You also can see that there are significant changes within this 12-hour time frame where the blood flows and the stroke volumes became really low, either in the expected range or below the expected range. In a second study, we looked at the level of diastolic dysfunction, and we found that indeed, also in our preterm population, about a third would have diastolic dysfunctions during septic shock. A second study, when we looked at early onset sepsis, which is much more harder to do prospectively. This is a retrospective look, looking at 18 very low birth weight infants with early onset sepsis. We found again that most of these babies would present with high stroke volume, hence warm shock. This was even more pronounced in the babies who had a gram-negative early onset sepsis versus the one who had a gram-positive early onset sepsis, which were more likely to have a normal stroke volume. And the same amount of diastolic dysfunction was found in this population as well. So this is surprising, but also puzzling, particularly if you look at it from a clinical point of view. Wait a minute, you have these babies which are in septic shock, and they have significant levels of cardiac dysfunctions, but despite all of that, many of these newborns with sepsis will present with high stroke volume, warm shock, and they actually have a lot of blood flowing to their system. Well, this can be explained by the pressure volume curve of the heart. Volume here on the x-axis and the pressure on the y-axis. And let's say we assume we're going to start with filling of the left ventricle, and then you slowly fill up your heart till at the end the mitral valve closes, and then you get to isovolumetric contraction before the aortic valve opens. The aortic valve opens and blood sort of spurts out till the end of systole before it starts in its isovolumetric relaxation time. And this is just one beat and one particular differences in pressure and volume within the left ventricle. But a lot can be read from this. And the differences between the maximum amount of volume which was in the heart and the minimum amount of volume is the stroke volume. The area under the curve is the amount of work which has to be applied by the heart. It's called stroke work. And of course, you can then measure pressure volume relationships at the end of filling, which we call preload, or at the end of contraction, which we call afterload. There's more measurements to be taken from them, also inside the heart, and systolic pressure and diastolic pressure and volumes as well, which you have to realize, particularly on the pressures, are different than what you get as a clinician without this kind of information, which is only systolic blood pressure and diastolic blood pressure. When we use physiology, you can measure the amount of pressure that needs to be applied to get a certain amount of volume change. And when we apply these particular lines to the pressure volume curves of the heart, underneath you see the preload in blue, you see the contractility in red, which has to press sort of the volume out, and then you see the afterload in green. And this would then be the baseline situation for that particular beat. Now look at sepsis. We've explained already that sepsis has an impact on contractility. It will reduce afterload and it will reduce preload, as shown here in the changes from the dashed lines to the straight lines. And if you then, under these circumstances, you build up that little block underneath it again, it will look like this. So what you're seeing is that the stroke volume, the difference between end diastolic volume and end systolic volume, has increased. The amount of stroke work has probably also increased, but also it's working at a lower pressure. Now this is called warm shock, where the changes are there with an increased amount of stroke volume, but this cannot go on forever. If these lines, and particularly contractility, sort of gets flatter and flatter, Then you get a situation where the box changes and gets really small, and you get a situation with low stroke volumes, which is called cold shock. And there has been debate about, how pediatric patients presents itself, because this is a fantastic study from 2008 from Joe Brearley in the UK, where he looked at 30 children with fluid-resistant septic shock. And they were admitted in the PICU. So they had to come from home to an ED and then into PICU, or from home to another center, or sent to the PICU before he got them. Those are the little the blue blocks. And he also had patients which came from his own sort of academic center. So those were hospital-acquired sepsis shock. And there was a significant differences between how these two presented in cardiac index on the x-axis and systemic vascular resistance on the y-axis. The expected range is shown there in the middle, and he showed that hospital-acquired shock were mostly with high cardiac index, high stroke volume, and low systemic vascular resistance, or warm shock. But the children who came from the community more likely would have low cardiac output, low stroke volumes, and high systemic vascular resistance. So hospital-acquired warm shock, community-acquired cold shock. And the initial discussions was, is this different because they're children or different kind of bacteria? But there's probably a much more easier explanation. Hospital-acquired septic shock is usually an earlier recognition, commonly between 8 and 12 hours after onset, while community-acquired is a later clinical recognition, so commonly more 1 to 2 days after the first symptoms of onset. So this explains sort of the timeline and the exposure and the sort of evolving septic shock. Cardiodysfunction in sepsis has this pathway which us as clinicians might enter into these pathways at different levels. Sepsis will give vasodilatation, tachycardia, hypotension, then there's already septic shock, and you can have hypoxia if you have PPHN, and then progresses into persistent hypertension or more profound hypotension, progressive cardiac dysfunction, organ dysfunction, and hypoxia and acidosis. So, and it is my understanding and experience in neonatology, and predominantly preterm infants, which might be very different if you work in an ED or in a pediatric intensive care, that the initial pathway, as we've shown in our studies as well, was almost inevitably warm shock in this population, and then there is a often sudden change to cold shock. This is an important concept about understanding the physiology of sepsis and septic shock, and then how we can apply our treatments. So let's talk about some of these treatments and some of the things which are now emerging as different approaches to septic shock. These are the two most recent sort of consensus guidelines and descriptors of surviving sepsis. The one on the right is from 2017, is slightly older, does not specifically exclude preterm infants, but practice parameters do mostly come from the PICU environment, and the one on the left actually excludes preterm infants in their descriptors. They do describe the three main components in there similarly, and even if you find some descriptors of preterm septic shock, you also find these three pillars of the approach to septic shock. First is fluid therapy, then they talk about cardiovascular medications, and then hemodynamic monitoring. So let's start with fluid therapy, and I'm going to start with a study from adults from 2001, because this is what steered our concepts and ideas for a very long time about fluid therapy in septic shock. This was called early goal-directed therapy, where they first gave fluids according to this scheme and measuring of central venous pressure, and then they started vasoactive agents. And this trial was highly successful. The in-hospital mortality reduced from 46% to 30%. So it was a great outcome, a great sort of a design trial, which gave these particular answers following this pathway. There was a second study done in the Netherlands in sort of a similar era, slightly later, similar sample size, which also repeated this finding, 42% versus 34% in hospital mortality. I think what then is sort of forgotten in the pediatric and specifically neonatal world, there were actually 3 trials thereafter. These trials were massive. They were 5 times bigger than the original cohorts. They were in different regions, USA, Australasia, and the UK. They happened in also the similar kind of time frame. And surprisingly, they did not find a difference with early fluid therapy SCTs. 18% versus 21%, so even higher mortality, not significant. 16 versus 15% and 25 versus 26%. So you have to conclude here that fluid therapy in adults with septic shock did not improve mortality. What they did find, though, there was a lower than anticipated mortality in both arms, and I looked at that very carefully, that the benefit in adults was mostly found from early detection and early referral. For example, the quick SOFA or other kinds of SOFA scores where referrals can be more efficient and quicker. Marek put these sort of trials in a different context and visualized them differently, and I think it's highly illustrative here. These are all the trials on the x-axis, mortalities on the y-axis in green, and the total amount of fluids in those trials given to those patients from 0 to 72 hours is in blue on the right. And as you can see here, there's actually a very clear relationship that the more fluids which was given in the trial in either arm, the higher mortality was then taking place. When you go to fluid RCTs in children, there are actually only 2. And I think most of us will be familiar with this from the Maitland trial from 2011. This was done in mostly African children with severe infection and poor perfusion as most presenting signs. They were given 20 mils per kilogram fluids over 1 hour, which was repeated if the impaired perfusion persisted. And here, the mortality in the group who received the fluids as their assigned arm had a higher mortality. The relative risk was 1.45, with a confidence interval which made this change significant. As you can imagine, there was lots of comments and concerns, particularly from practitioners in the developed countries, which say, well, this is not our population, it's different kind of diseases. But if you look at the details of these patients, I think a lot of them are comparable. And it took until last year before this trial came out, where they tried a pilot trial of restricted fluid bolus volume in early septic shock. And this is the Fluids in Shock pilot trial from the UK. 10 mil per kilogram versus 20 mils per kilogram, repeat every 15 minutes if still in shock. Now, in this trial, there was no mortality and there was no difference in clinical outcomes. But just like they found in the adult trials, where there are now new referral pathways, we have, for instance, the Sepsis Kills slogan and educational relays to have early referral of these are children with shock to the EDs. These participants were not as unwell as expected, and most received just 1 fluid bolus. And they said, well, look, this is a pilot trial, but the data we have now, we can't do a bigger trial. So trials and randomized trials, probably not the way forward to find out what is the optimal fluid therapy in septic shock. But we can still look at other data which is there, which are now overloading us from different kind of situations. This is a study with 202 PQ patients with sepsis. This is from China, where they looked at fluid accumulation, which is the increase in weight, less than 5% or over 5%, and they found a significant differences, whether this was in the first 24 hours or to total PQ admission. Sort of a similar trial and descriptor described much more patients, but only 90% with sepsis, and this time from the UK. They did not find that fluid overload was associated with mortality, but they did find that it was associated with morbidity. And particularly the mechanical ventilation days, if you had more than 10% fluid overload, was a significant increase in the amount of days those patients needed respiratory support. And this can again be explained with physiology. This is the Frank-Starling curve. On the x-axis, the central venous pressure or the preload. On the y-axis, the stroke volume your heart can create. If you're on the right end of the Frank-Starling curve, and you give fluid, most patients will respond to fluids as expected. If you're sort of in the middle of the Frank-Starling curve, I think the response to fluid therapy can be unpredictable, but particularly if you're on the right hand of the Frank-Starling curves, most patients will not respond to fluids because there is an equal relationship between preload and extravascular lung water. So all that extra fluid you're giving then will end up most likely in the lungs, hence the need for increased respiratory support. This is a very recent study which looks again at fluid overload and mortality. This time it's in 56 preterm infants with late onset sepsis. The overall mortality of this cohort was 22%, so there's pretty sick babies. About a third, and this was the focus of this particular trial, developed acute kidney injury, and more than half of them of quite serious kidney injury, stage 2 or 3 AKI, which had a six-fold odds of mortality. But look at the babies who got early fluid overload, more than 10% increase in weight. This was about a quarter of the babies developed that at 21-fold odds of mortality. So this is another paper, and there are many more of them, particularly in the adult literature, which shows that there is a clear and consistent association between fluid overload and adverse clinical outcomes in patients with sepsis. And I want to add, in any age group. So the adult world has recognized and realized this and are now trying to design new concepts and trying to design, if it is possible, novel personalized approaches to fluid therapy in sepsis. I'm going to explain some of those approaches they are now doing in most settings in the world. This is just a reminder how the difference between true hypovolemia and preload differences in sepsis, that is actually a relative hypovolemia. You need to know that this fluid is actually still in the patient, but you need to get it at the right place. So will a newborn with septic shock and relative hypovolemia benefit from extra fluid? So fluid ends up as stress volume and can be used as stroke volume and pressure generating, which means the patient is fluid responsive. Or on the other end, fluid ends up as unstressed volume and thus as extravascular lung water and edema, which is not fluid responsive and likely leading to clinical harm. The way to measure fluid responsiveness can be done in two ways. One, during induced changes to the loading conditions of the heart. Now, how can you induce changes to the loading conditions of the heart? You can change your intrathoracic pressure, or you can increase your preload. So changes in intrathoracic pressure can be done with changes in mechanical ventilation, particularly during inspiration and expiration. And changes in preload can be done in adults with a passive leg raising, and I will explain later much more detail about the mini fluid challenge. So with positive pressure ventilation, the pressure is higher during inspiration than it is during expiration. And we already know from physiology, if you then would have a detailed look at the arterial waveform, you can see variation with these changes in pulse pressure, which is called pulse pressure variation. So the differences between the systolic and diastolic pressure within the arterial waveform will increase with the duration of inspiration on mechanical ventilation, and then sort of change again during expiration. You can also look with ultrasound. Instead of looking at the arterial waveform of blood pressure, you can look at the left ventricular outflow waveform, and this is then called stroke volume variation, which follows the same pathway as the arterial waveform, with an increase in difference between minimum and maximum velocity with the increased time on inspiration. This is an example I took from one of my patients here. There is a blood pressure waveform on the top, and you see the pulse pressure minimum and the pulse pressure maximum, and underneath it is your airway pressure waveforms underneath. And as you can already see, these are not sedated and paralyzed patients, which comes to be one of the problems in our neonatal intensive care population using this particular technology. This is an example looking at stroke volume variation during mechanical ventilation. And again, you see the differences between the maximum and the minimum of those peaks velocity times integral on ultrasound, which is associated with breathing. And getting a breathing trace and an ultrasound trace simultaneously on a screen is not that easy. When they looked at these fluid responsiveness on mechanical ventilation studies, you see there are 15 studies in adults, which are over 650 patients, which you can see on the right, where the sensitivity and the 1- specificity, so the ROC curve of diagnostic accuracy is depicted. That is actually a really good line. Slightly less studies in children, only 6 of them, again, with very good sensitivity and specificity, using a cut point of more than 50% of changes of assigning a patient as being fluid responsive or not. But I already highlighted some of the limitations of using this particular technique. It is only valid under the following circumstances. There must be no spontaneous respiratory efforts, which I think in our neonatal population is a significant issue. Tidal volumes have to be around 8 and sometimes even higher. Some now suggest you have to go higher. Mils per kilogram, again, not ideal for a 600-gram preterm baby. I think the other things, sinus rhythm, normal intra-abdominal pressure, and closed chest are less relevant, but those two highlighted in red, significantly limiting using this particular test to looking at the patient's fluid responsiveness. What else can we do in adults? To do the passive leg raising that looks like this. They're on a specific bed. You angle it 45 degrees and then you angle the head down for a certain amount of time. And then again, you look at that arterial waveform, or you look at ultrasound parameters, which in our, again, NICU population would not be reasonable. What would be reasonable for us, and what we're trying to test out now, is measuring this dynamic fluid responsiveness by using the mini fluid challenge. Here's again the Frank-Starling curve. You have preload on the x-axis, stroke volume on the y-axis, and the Frank-Starling curve depicted here. Now imagine you're on the left side of the Frank-Starling curve, and then you give a fluid bolus. What will happen then, of course, you change, you move up the Frank-Starling curve, and after the fluid bolus, if you would then measure again, you would see a significant increase in stroke volume. However, if you're on the right end of the curve, and then you give a fluid bolus, those changes will be way less pronounced. So this is called, these are the principles behind the mini fluid challenge. This is what it looks like in real life. This is a stroke volume of a preterm baby before a fluid bolus. Then we give measured sort of the peak velocities which are available there. And then we give a fast fluid bolus, 3 mils per kilogram over 5 minutes. And then you measure the stroke volume after the fluid bolus. So you can then see the changes happening or not, of course, depending on the baby, which is a change in peak velocity, which if it's more than 50%, 15%, 15%, then that would be associated with fluid responsiveness. And this is our pilot data. There is more data in other patients, but I've only selected here the patients which are preterm babies with late onset sepsis, where the clinical condition was sepsis and the indication for prescribing fluid was either hypotension, poor perfusion, and one baby with tachycardia. The percentage stroke volume is depicted here on the right. And as you can see, there were 3 patients which went over that 15%, but the other patients did not, although they did show some sort of change in stroke volume as well. There was more interesting data to be found in this pilot as well. When you summarize these 11 patients with late onset sepsis, we found that indeed 3, which is about 27%, were fluid responsive, and 8 were not. What was important that these 8 actually did change in oxygenation index 4 hours after the fluid bolus was actually significantly higher than the ones who were fluid responsive. So this fits with the sort of physiology, the physiological principles of stroke volume and extravascular lung water changes that makes this test most likely a suitable candidate to be further studied in our population. Of course, we need more research on dynamic fluid responsive tests. We need to know what is the optimal bolus volume. In adults, they found out that the smaller bolus given faster was at best, so this was why we choose that. then I think they can certainly have a debate on what is the best ultrasound parameter to use to look at changes. As a clinician, it is important to realize that fluid responsiveness does not necessarily mean that a patient should receive more fluids, because there is no direct association between this fluid responsiveness and clinical outcomes. However, you can prevent fluid overload using this particular situation, but you have to put, number one, the clinical context. For instance, degree of cardiac failure or the degree of renal failure, which makes you decide if more fluid is required in this particular situation. I'm going to do a couple of slides now on the second part. Now we closed off fluid therapy, which we know that too much fluids leads to morbidity and sometimes mortality. And I've shown you that there is a possible test which can help us predict which baby are more likely to need fluid, or particularly the baby who you shouldn't give more fluids to. Now we're going to go to the second pillar, which is cardiovascular medications. Do you use a vasopressor or an inotrope in an infant or a child or a preterm infant with septic shock? Well, I think that question has now become increasingly easy, particularly if you're able to measure stroke volume. So you can take any kind of stroke volume from any kind of blood flow measure. I usually take at least 2, so I know for sure what is there. If you have very high stroke volumes, as shown here, which is then called warm shock, particularly if you have high stroke volume, low blood pressure, which is warm shock, and then you give a vasopressor. On the other end, if you have a very low stroke volume and a low blood pressure, that means there is high systemic vascular resistance, which is called cold shock, and then you're much better off with an inotrope. This has been tested, particularly the treatments for cold shock and their effect of inotrope versus dopamine as being beneficial in 3 particular trials. There are, however, no trials looking at, for instance, dopamine and noradrenaline, which particular vasopressor would be ideal in warm shock. We also looked at the timing of treatments. This is a large cohort which described 279 very low birth rates with late onset sepsis. And then there were 25 infants, which is 9 infants who progressed to septic shock, and they are detailed below. And what is detailed below is the timing to treatments. So this is in the hours after taking your blood culture, which in this population was all positive as the definition of sepsis, and then with hemodynamic compromise as definition of septic shock. So we were very quick in our center to blood culture and then give antibiotics and have them in. Then you take some time to optimize respiratory support, either intubate or escalate, whatever you need to do. We took about 3 hours to give them the first fluid bolus, but probably what was most surprising, it took us on average 12.3 hours to start a vasopressor in babies who had septic shock and were progressing with more and more hypotension. So that's a long time. Now, if we go back to that original sort of description of all these studies in adults, and of course, there's a massive studies with lots of data, and there is way more data sort of coming out of it. Here, you can also look at the timing of vasopressor therapy. The green line was the mortality with each trial, a lower mortality, the fluids with each trial, less fluids, also leading to lower mortality. But there was another factor, which is the vasopressor use in the first 6 hours of their entry into the trial. And this is absolutely also astonishing how this almost mirrors the mortality rate. Early use of vasopressor here was associated with a lower mortality in these 5 big trials. And earlier than what is earlier, these only reported, most of these trials reported vasopressor use in the first 6 hours, sort of what the 6-hour mark is. But for instance, this trial, very recent in adults with septic shock, they actually took the marker more around 3 hours and could already see a difference in the time to shock resolution in hours. So this earlier use of vasopressor seemed to be beneficial into the physiology, the pathophysiology of sepsis, which to me makes lots of sense. It's vasodilatation, which is the problem. It's relative hypovolemia. So if you constrict these vessels, that's the primary contributor to what we call septic shock. There's even one randomized trial, which is done from Thailand. It's an excellent trial, which looked at early noradrenaline 1.5 hours from arrival in the ED. This is adults again with septic shock, or standard noradrenaline 3.2 hours from arrival in ED. And they also found earlier restoration of blood pressure targets and clinical perfusion, shorter duration of mechanical ventilation, less fluids was also used in the earlier noradrenaline group, shorter ICU stay. There was no difference in mortality, but the physiology, the treatments, and all followed the pathway which makes most sense. So I'm going to do, these are the last slides where we can start some discussion about these new concepts. So I have highlighted these emerging new concepts in septic shock. They are from the adult world and now have tapered over into the pediatric world. And I think it's time we need to think about this and incorporate this and test this in our newborn population. I am certain that the physiological principles as applied in adults and pediatrics are the same in our newborns. Yes, we have shunts. Yes, we have maybe, we have a smaller range of when a baby's heart is going to be compromised by afterload, but the physiological principles are the same. We also have seen in studies that too much fluid is associated with morbidity and mortality, and we need to find ways to help us do restrictive fluid resuscitation. I've shown you the sort of the first pilot data of ultrasound parameters to prevent fluid overload, the mini fluid challenge, which has now become almost guideline standard of care in adults, where you can now read papers about how that now has changed outcomes overall. And I showed you the most likely benefits of the early start of noradrenaline if you have recognized warm shock. Now, this, of course, will have logistical ifs and buts, and how we're supposed to do that. And we can talk about that during the discussion. I think these three are very promising, and further testing in newborns is required, either through prospective trials. I don't think the randomized trial will be a suitable way, as most of us before us have shown that this is very hard to lead to full recruitment. There are others which I haven't mentioned, and I think are probably a bit less suitable for the particularly preterm population. If you have septic shock, you can target the peripheral perfusion, usually looking at the microcirculations. There are different modalities available. One looks with a laser on your skin, another looks with an actual microscopy to the size of the microcirculation under your tongue. I know there's been some pilot trials in particularly term babies who have some sort of idea about it, but I haven't heard much sort of thereafter. Early correction of fluid overload, which is an option in adult world and in the PICU. There are some promising progresses now also in newborn peritoneal dialysis and different kind of catheters, which can help out particularly in the bigger of babies, but it certainly wouldn't help us in the preterm baby. I haven't mentioned or highlighted the specific use of vasopressin. There is different data out there which say it's the same as noradrenaline, and other would comment that you can use it specifically to target these pressure volume curves. Because using different inotropes or inodilators, with looking at those slopes of the contractility and the slopes of the afterload, you can see what each of your different treatments has actually created in the heart. And the last, which is, I think, certainly still experimental, is modulating the adrenergic response on a receptor level. So I thank you all for listening, and we have time for some discussion.
Thank you, Koert, for that amazing insight into the need for assessing neonatal hemodynamics in babies with septic shock. Whilst we wait for questions on the chat pane, you can also unmute yourself to ask the question. Koert, do you think ultrasound should be a part of standard care in NICU intensive care newborns with sepsis and septic shock?
Look, you know me, and I'm going to definitely answer yes. This is a disease with 30 to 40% mortality. And we now have the opportunity, if we would train ourselves to at least recognize this and find ways to then modulate and follow our treatments. There are often treatments installed where it's a bit unclear of what the effect is like clinically. You might get a change in blood pressure, but not a change in blood flow, or vice versa. And I think ultrasound is probably the only way to show you and where you can target a treatment and monitor response.
Thanks, Kurt. And how difficult rather is it to ultrasound babies with septic shock? Because normally babies do deteriorate quite rapidly, and that's
yeah. Look, the first assessment looking for a high stroke volume or low stroke volume is actually very simple. So that is something which most of us can master in a relatively quick way. Then looking at those intricate changes of cardiac dysfunction, shunts, and pulmonary hypertension, that requires a full training of cardiac ultrasound and neonatology here in Australia, regulated and trained through the ASIM, where you definitely have to teach that skill, learn that skill, and master that skill.
It often happens that there might not be many people who can scan when a baby falls, becomes very sick. We do have a question from Nick. How did you come up with the 15% increase in max LVO velocity as the threshold for significance?
Yeah, I think Nick, that's a good question. How do I come up with it? I didn't come up with it. I just used it from the literature, and there are certainly some considerations here where I'm not sure what is the right answer there. Adults have much stiffer vessels, so the change which you can measure there can be different. The dilatation might be much more in our particular population, so the flow velocity will be lower. So maybe a lower threshold is more appropriate in our particular cardiovascular population. They did look, particularly in adults of all sorts of ages and in children as well, and they use different kind of cut points to see the differences. I guess the exact amount is maybe not that important. So they now, first they mastered this test, the mini fluid test, and now they're applying this into their practice and showing that if you use this way, you're less likely to be overloaded, you have less mechanical ventilation days. And I think that is probably the most important part. If it's 15, 14, or 12, you need to take at some point, some cut point, where you say, now this baby, I'm not going to give any more fluids because I'm now likely going to lead to fluid overload. So it's more the other way around. In the adult and PTQ flow diagrams, you see that they often don't use one measurement, they use different measurements and see how they all add up into the same answer.
We have another question from Dr. Sanjay Wazir. What is better for initial fluid bolus, ringer lactate or normal saline for neonatal septic shock? There is data from children, but what are your thoughts in neonates?
Yeah. To be honest, this has not been properly studied. And if you look at there's various components to this particular question. One, what would I suggest? Our guideline would suggest normal saline. Would ringers or maybe even a much more larger component like blood, for instance, or FFP, others be more beneficial if you want to keep it into the circulation? There's animal data which show that all of this stuff doesn't stay very long into the circulation. And I think, I hope you got this particular message, because I'm not saying don't give a fluid bolus of sepsis. I also always first give a fluid bolus. But I'm certainly thinking about the second one or the one thereafter before you make any decisions. But the primary pathophysiology is vascular leak and vasodilatation. And the treatment for that and focusing on that might be much more important.
Also, Kurt, are there any other ultrasound parameters besides the VTI that can help determine fluid responsiveness?
Yeah. So there's some data out there which looked, for instance, at the diameter of the vena cava inferior or the vena cava superior. There's differences between the two because the vena cava superior is all inside your thorax, so has a much more accurate way, I think, of looking at differences between inspiration and expiration. While the one of the IVC, particularly if you have a spontaneously breathing baby on the ventilator, can be a bit more difficult to interpret. So those will be the two others ones which are commonly used, but depending on the situation. For instance, doing high frequency ventilation, both the IVC and the SVC are likely to be not as useful.
We have a question from Srini. Srini, do you want to unmute yourself?
Thanks, Rahul. I think Kurt has already answered that while I was typing it. I think he discussed, he's saying we should still go ahead and give the initial fluid resuscitation. That's not this talk about. This is more about frequent fluid boluses after the initial fluid resuscitation. That's what I was just writing it, and then, yeah.
Look, I agree, Srini. We all have our fluid there. I used to prescribe 20 per kilo. I'm now certainly doing 10 per kilo only, and then start to analyze and see if that baby needs more fluid. And I've, like Nick asks here in the test, should we start early, vasopressor earlier? Yes. I definitely think so. Now, what is the point? Sometimes we have all seen babies, and I think it's about 20 to 30%, you give a fluid bolus and the problem is solved. So of course that baby should maybe not be on there. But so that point is much harder. In our original prospective study, we found that the change from warm shock to cold shock was within 12 hours. And I must admit, practically it's probably within 6 hours. So these are the babies which are progressively getting really ill really fast. And those are the ones where we should not hesitate of starting vasopressors earlier.
Also, we have another question from Nick. Should we be starting vasopressors earlier than thinking about fluids? And practically, how do you think we can achieve earlier start of vasopressin in newborn infants with warm shock?
Yeah, so I highlighted, I think, a little bit before on this. How should we do it? Because we need a long line, which is an intervention in a sick baby. I haven't figured that out yet. I do know I've over time set my threshold for deciding of no long line and noradrenaline at a much lower threshold than I used to. And I think that's an important sort of a way forward.
And I think there's another question from Dr. Rajesh. Is LAAO a good indicator of intravascular volume status?
So that's on the left side. So you're measuring, it's a measure of left atrium volume, and left atrium volume is quite influenced by left atrium pressure. And as I explained, in sepsis, you often have some sort of cardiac dysfunction. So left atrium can actually be quite enlarged, but doesn't reflect the sort of total preload situation of the right atrium. So the right atrium is where the central venous pressure sort of hits, and most of the measurements looking at total fluid status are on that particular end, either IVC or SVC or right atrium size, and sometimes even right atrium function. There is a difference between total fluid status and fluid responsiveness. The fluid responsiveness is much easier determined from the Frank-Starling curves, and in particular the Frank-Starling curve of the left ventricle. So left atrium size, and particularly left atrium pressure, maybe even left atrium function, if you're capable to measure that, which can be done nowadays with more advanced kind of measures like speckle tracking, can give you information about the underlying pathophysiology. It's a step beyond hypotension or stroke volume. Then you go into the intricate measurements of cardiac dysfunction during sepsis, and there is quite a bit of variation from patient to patient of what you will find.
Srini would like to make a comment on vasopressor. Srini, would you like to unmute yourself?
Thanks, Rahul. I think just again the same thing at the bedside. because we looked at the time it takes from the time you prescribe a vasopressor, either dopamine, dopamine, or adrenaline, and actual time it goes into the baby. It on average, it took about 25 minutes in practical terms by the time you write it, and it actually, the first drop goes into the baby. So I think the fluid resuscitation is still an important part while waiting. Is that right, Koert?
Yeah, no, I agree with you, Srini. And I think 45 minutes is even rather fast. And what do you do in that situations? We have measured all our lines, which are for usually everybody uses slightly different brands and slightly different pieces in between. And we made sort of all our common combination, and we filled it up with fluid, and we measured the amount of fluid. So that's the purging amount of fluid, and a little bit sort of 10-20% less, which we use in these particular critical situations, but only in these particular critical situations, to have a shorter time. And I think now we apply that every now and then. I think the time is now within 15 minutes. So still 15 minutes where you have to sort of address sometimes a very low blood pressure.
Thanks, Koert. We have a last couple of questions from Dr. Gayatri and Dr. Sripada Rao. So the first one is, any comment on vasopressin as an inotrope compared to NORAD? And Dr. Sripada Rao says, which one is more common, cold shock or warm shock?
Well, the vasopressin question is a really relevant one, because particularly in the adult world, they say it doesn't matter, take vasopressin or noradrenaline. They actually tested it out in a couple of randomized trials and found that there was no specific difference there. There's less data already in PQs in children, and there's even less data in preterms. I guess how vasopressin works, its water retention and its effect on saline, it's maybe more complex, particularly in the preterm population, as their whole system and it has not been fully developed. I don't have that much experience with it. When we used it in these situations, we used it late and it wasn't very successful. But that's, of course, not an answer about what to use. When I spoke to some of my sort of hemodynamic colleagues around the world, what do you do? Most would not use vasopressin in a prim baby, maybe in a more term baby when they have some more experience about particularly the changes in sodium and water. The question about cold or warm shock, I'm a neonatologist. For me, warm shock is the most common thing I find. But like I said, if you work in an ED, it could be half-half. If you work in a PQ, it could be half-half. So it really depends on where your patients are coming from. I would think that if most of your septic shock patients are from within your hospital, you will more likely 80-90% see warm shock. So, you could argue, well, let's just start treating warm shock from the beginning if that's your most commonest sort of situation. But like I explained, I think measuring stroke volume is so simple that I think it should be part of our care of babies with a really high mortality.
Thank you, Koert. Also, Dr. Sanjay Wazir says, when you consider hydrocortisone as a vasopressor in neonatal septic shock, almost 30.
I think I would do the same as anybody else. Once it doesn't respond to the first inotrope, whatever you're given, we generally start some hydrocortisone as well.
Yeah. It's 2:00 and we come to the end of today's session. Please log in your attendance with the QR code on the screen. And thank you once again, Koert, for this amazing talk.
Well, thanks for inviting us again. And we'll see you all next week, where we continue our talks on sepsis. I think Tobias Strank is going to talk about prevention of how can we prevent particularly late onset sepsis in our population. Thanks for attending, and I hope to see you all next week.
Thank you.
All right. Thank you. Bye.